So welcome back to the second session.
Sure.
I hope you are not hypoglycemic anymore. So I think we start. We have a slight change in the program, just an inversion, and we start ladies first. So I'm a big pleasure to present Berna Özdemir. Please come here. Gender and sex, very political and prominent topic. But gender medicine is a topic which we know already since at least 2 decades, but not gender oncology. So that's a very, very new topic. Thank you very much. Berna is MD, PhD, medical oncologist. Now is in Berne, but he had a long trip to Berne and had the postdoctoral training in Harvard. But Israel's MD Anderson. And the way I get to her is because of this new ESMO task force, which is on gender oncology, which was also co-founded from Berne. So thank you very much. We are very happy to have you here. Please.
Thank you very much, Dr. Milani. It's a great pleasure to be here for this Integrative Oncology session at this beautiful location. So my background is in preclinical cancer research. I'm a clinician mainly treating melanoma, renal and bladder cancers. I don't do breast anymore, has been years. So I try to show you what you need to know when it's about gender medicine. And the title already tells you basically my take-home message. So sex and gender affect cancer risk and outcome, and we need really to be aware of that. My disclosures. Before starting, I would like to give a definition because I assume that not all of you are familiar with that. And the terms sex and gender are often used interchangeably in scientific literature, but they are important distinctions. So when we talk about sex, this is a biological variable. So meaning a cell, each cell has a sex, each animal and person has a sex, and this is usually binary, so either male or female. Rare exceptions are intersex people, and this is based on the chromosomes and gonads, so something biological. Gender, on the other hand, is a purely social construct, so therefore it's rather a spectrum of characteristics, and it's based on the roles and stereotypes which are prevalent in a culture and depending on the zeitgeist, okay? So therefore, gender applies only to people, not to cells, not to animals. And as I said, it's really based on stereotypes and roles, and it's a real hot topic because with societal changes, what a person needs to do or how he needs or she needs to behave to be considered as a man or a woman, a boy or girl, depends totally on the cultural background. And also the wording is important. When you talk about sex, we usually use male, female. That's the correct wording. When you talk about gender, you refer to people as man, woman. And gender is really very, very complex. If you talk to people studying gender, there's gender expression, gender identity, then comes in sexual orientation, and so on and so on. So I will not go into that because the whole thing, sex and gender, influence each other also throughout a life cycle of an individual. You can see that already lifestyle factors such as nutrition affect an embryo before birth, and then with the sexual hormones, we affect our lifestyle or we determine our lifestyle. So to illustrate the complexity, you have to think of sex and gender in a human being's life as this entangled cable salad, I call it. And what we do when we work in gender medicine or when we do study sex and gender is try to really disentangle that and try to come up with ideas and with concepts, okay? It's a really oversimplification when we talk about sex and gender differences. Here, my research mainly focuses on sex differences and not that much on gender because, as I said, this is a very complex construct. Okay. Now, so when we start from cancer risk to cancer outcome, at all levels, both gender and biology, sex factors influence this risk and outcome. I will not go through all of these factors for the sake of time, but I will give you an example of the cancer risk, how this is influenced by sex. So we know globally, worldwide, since the inception of cancer registries, that male sex is associated with a higher cancer risk. And in this graphic, you can see that independent of the geographical region, so be it Europe, Africa, America or Asia, males have a greater cancer risk. And also they risk to die. Sorry, I need to maybe go through there. I was trying to give the pointer there. So if you look here, this is the incidence. This is greater in the male population, maybe with the exception of thyroid cancer. This is a disease which is basically diagnosed in women in 90% of the cases. And when it comes to mortality also, the mortality is greater in the male population, independent of the geographical region and the cancer type. So what are the reasons for that? These differences are known for decades. And the first theory why this happens was that lifestyle factors such as alcohol and smoking are more prevalent in the male population. So that's why men get more cancer or more frequent. But that's not the whole story, because even if you normalize for those factors, these differences remain. Okay, so there are some biological factors which we are just beginning to understand. Now, I will skip the whole part about carcinogenesis, the effect of sex-related factors such as the differences in the immune system, genetic, epigenetic factors, or the body composition and anatomy on cancer diagnosis. And one important thing, which is the access to treatment and health literacy. They are very, very important gender differences. I will focus on mainly on this part, which is the outcome. So they are really significant outcomes based on sex and gender of a person. And here focusing on toxicity. This is my the focus of my research, which is, I think, a fascinating topic and affects a lot of people. So as you can see here in this meta-analysis of clinical trial data from America over the last 40 years, here they looked only at cancers which occur in men and women. You can see that female sex is associated with a greater risk of toxicity across those main treatment modalities. And this is in the range of 35 to 50%, which is really clinically relevant. We cannot just say this is an academic issue. This really is true. And if you now know about the topic, probably you will say, yeah, that's true. In my practice, when I treat patients, I know that women are more affected by nausea, diarrhea, have more hematotoxicity, and this is well documented. There's tons of data on that. So what are the reasons? How can we explain this greater toxicity in the female population? So first of all, the way we dose chemotherapies, for example, we dose them according to the body surface area. This is very imprecise. We know this for decades. Also, there are already papers written in the 70s that this is not a good way to dose. But we don't have anything better for the moment, which is established. So we continue doing that with the fake pseudo exactitudes. I have to laugh. There are some residents, they come and say, should I give them like 587 milligrams of a drug? I say, who cares? You can also do just like 500. It doesn't matter. It's just you feel better because you think you gave it very exactly, but probably doesn't matter. So one issue with the body composition is the lean fat-free body mass. So basically the muscle mass is greater in the male, in males as in females. So if you have a man and a woman of the same height and weight, they will have the same body surface area, but their body composition is different. So the male has more muscle and will have a greater clearance of the drugs. So they will, the male will have less, let's say, the blood levels will be not that high in the male person getting this drug than in the female. So this is one of the reasons for the greater toxicity. There's also a lot of data with different drugs on that. Sex hormones, of course, the level of sex hormones depend on age. They affect many of those drug metabolizing enzymes. And sex chromosomes are very important for immunotherapies probably, because a lot of the microRNAs which control, regulate immune-related genes are located on the X chromosomes. And we know that the immune system of females works differently, is more active, and that's why immunotherapies might not work the same way in females. Now, when it comes to pharmacokinetics, at all levels, from absorption to excretion of a drug, you have differences. From the pH in the stomach to metabolizing enzymes at all levels, many differences are described. So basically, you can think that in most cases, when you give the same dose of a drug in a female, you will have higher blood levels, which will translate in greater toxicity. But important also, this greater toxicity is not always correlated with a greater efficacy. So women do not live longer because of that. There are also several meta-analyses and pooled analyses which have shown that. That's why this is so important. We cannot just say, take this into account, you have greater toxicity, but you will live longer, you will have a better efficacy. That's not true, because probably also drug effects, the dose-response relationship is different in a man or woman. Now I would like to get to the second part. So those were the biological differences which explain some of these data. But the main issue is, I think we have a great data gap, a gender or sex data gap, if you want to call that. This starts already at the level of experimental research. So when you are developing a drug or testing something, usually you do in vitro testing on cancer cell lines. You do a drug screen. This can be nowadays done also in silico, with computer programs, but the classical way is in vitro. We know that sensitivity of cancer cells derived from tumors arising in men or women is different. Also, even the culture media contains products which have like a hormonal effect. This phenol red, for instance, is something like an estrogenic compound. This is all known, and we know also in animal experiments, most animal experiments are done in males only. So this is based on a wrong assumption. It has been shown that it's wrong on the assumption that also the female mice and rats have an estrous cycle, okay, like humans. So researchers were thinking that this might lead to more variation if you do an experiment with female mice. So just to be on the safe side, just take the males. I mean, this is a crazy idea. You scotomize half of the population because you want to get nice results, but the drug you develop or the results you develop will then be extrapolated to also females, right? Female people, the women have a cycle, and they get also, it's messed up with birth control pills and with menopause and so on. So it doesn't make sense to scotomize that. And we did recently a survey among academic cancer researchers working in different institutions all over the world. We got response from 1,200 of them. And we just asked very simply what they think about the study of sex differences. And you see, this is here, it's summarized. You see, although most of them said they were familiar with the study of sex differences, when we asked them what do you think about reporting of the sex of the cell line which was used, about half of them said it's not important. Okay, when we asked, do you know the sex of the cell lines you use in your experiments, half didn't know. And 1/3 didn't think it was important to do experiments with both cell lines. Okay. I mean, one can say, yeah, this is shocking because it's such an odd topic, but I worked myself in a lab for many years, and before working on that topic, I never thought about that neither, okay? You have your cell lines, you don't even know from which tumor, which organ they come from, you just do what everybody does. So we need really to tackle that and raise awareness on that topic. The second thing is when you have identified a drug and you want to test that and bring it into clinical testing, you need to know about the pharmacokinetics. So how does this drug work? And here the issue is the reference person to test a drug dose is usually a male, 70 kilo, white person. Okay, and all the other people were obese, not male, not white, Asian, black, who are maybe underweight and old are not taken into consideration. These are considered deviations of the norm. So this is the norm. And we talk about diversity, inclusion. So our research is based on a norm, on a male norm, and we need to extrapolate from that to a lot of different people. Okay. And when you look at different drug classes, you see that for 22% there's no data on potential sex differences, but on 20%, 20% have clinically relevant sex differences. So this is known, but what is the consequence of that? We just know that, but we don't know, should we give a different dose? What should we do? A data gap, important data gap. Then if you move on with the drug testing in clinical trials, so you manage to develop a drug and you bring that in testing at all levels from phase 1 to phase 3, the rate of female inclusion or female participation is not adequate. So globally, the ratio male to female in clinical trials is 60% to 40%. Okay? And this didn't change over the past 20 years because historically this came from an initiative after the Contergan scandal after World War II to protect females of childbearing potential from the potential harmful effects for the embryo, to giving those women drugs which were not tested. Okay, but then this was starting from a good intention, but it was interpreted really largely. So females were not included in clinical trials. And you see here that despite the initiatives of the FDA and NIH to include more women, this has remained stable. So from 2000 to 2020, this didn't change much. You see 40 to 60, and also it's independent of the geographical region and of the tumor type and stage. So there also we need to tackle that. And another important issue related to clinical trials is the reporting of the results. So when you read a paper on a clinical trial, you see those forest plots with subgroup analysis. There, often sex is in those subgroup analysis, but only for the primary endpoint, mostly. And if the primary endpoint is overall survival, you will have a result. I will show you an example. But for all the other endpoints, you don't have this data. And it has been also shown that this type of subgroup analysis are often of poor methodological quality, so that you cannot draw any meaningful conclusions, because what is done basically is the variable sex is taken into consideration, measured at the beginning of the study, but nothing more. There's no hypothesis pre-specified, so you don't know what to expect. Do you have an hypothesis? Nothing. So we don't know what to do. And to illustrate that, I would like to take the BILCAP trial. I don't know who of you treats biliary tract cancers? Some of you. So I think this is a controversial trial, or at least there should be some controversy regarding that trial. It's a phase 3 trial, which looked after complete resection of biliary tract cancer, whether giving capecitabine versus observation, whether this changed anything in overall survival. So primary endpoint is overall survival, which is, I think, nice for an adjuvant trial. This is really rarely done. So you see, this trial also was well performed because the ratio of female to male was 50% in both groups. So this is really nice. When it comes to the results, you have again a forest plot. And here you see the confidence interval for hazard ratio crosses 1. It's from 0.64 to 1.35 for females, indicating that giving capecitabine might be detrimental for women. Women might live less or have a shorter OS if under capecitabine, you see here, compared to men where this doesn't cross 1. So was this mentioned anywhere in the paper? What is the conclusion of that? Nothing. The interpretation of the paper is that the overall survival is improved with this drug and it can be considered standard of care capecitabine. Okay? So that's fine. These are the authors of the paper. But what does the ESMO do? ESMO has done guidelines which are followed throughout the world. We know that they are well followed. And you see this is in the guidelines. And there's no sex-specific recommendation. If you read those guidelines, not going into the raw data of PILCAP, you discuss that for patients, for men, women, after resection, you should give chemotherapy. But I think it's extremely hard. If you have a patient, and if this patient has read a little bit or has somebody in the family who is a doctor, comes into your consultation and you need to discuss, it's a bit challenging. What do you do? Should we say, don't get capecitabine? But we don't know. This was not a trial powered to show any sex differences. It's very, very, very hard. So with this, I would like to close. So I think there are many structural barriers for us to develop sex-specific drug dosing and treatment strategies at all levels. So I showed you these are the biological reasons why we have greater toxicity in women. But what we can do is really tackle the design of clinical trials and reporting. We need to make sure that we have reporting segregated by sex and pooling data from different clinical trials. And to do that, to really have statistical power. And to have that, we need to increase awareness at all levels, starting from experimental, preclinical research, but also the pharma industry needs to share this data. It's rarely impossible to get access to this data. And also the agencies such as FDA, Swissmedic need to be aware of that issue. One last point for those of you who think this is a breast cancer conference, come on, why gender? Look at that. I showed you the gender data gap affects mostly women, but it affects also men. If you think of breast cancer, 1% of them are males. How do you treat them? According to data which is established in trials only for women, basically, right? So if you are a man having breast cancer, you actually don't know what you get. It's as good as it gets because there's no data. So maybe next time you think about that. I would like to show you another example, which is osteoporosis. I mean, all of you who treat breast cancer patients, you are very aware of that. And also the patients are luckily very aware and ask about osteoporosis issues. Here, in a study from Italy, they analyzed the sex of the patients who consulted in an outpatient clinic, and you see that 95% of those were women. Only 5% were men who consulted to check for osteoporosis. Why is that important? Because in women, osteoporosis is basically something related to menopause, while in men, 2/3 of them had secondary osteoporosis related to drugs, other diseases, comorbidities. I treat a lot of prostate cancer patients, and I can tell you until a couple of years ago, nobody was aware of the risk of osteoporosis. It just made it into the guidelines that we should also check and give bone protection. And just as a last remark, so because this data is established in women or generated based on women, we don't know actually how those technologies perform to predict risk of fractures in males. A data gap which affects males here. And with this, I would like to conclude. I hope I could convince you that really sex and gender is important. There's a male bias in research, and we really need to improve design and reporting of clinical trials. And to me, gender medicine, many people understand something else on that. To me, this is really part of precision oncology, precision medicine. Gender and sex are so basic variables which are in general known and available and affect so much of disease and health that we need to take them into consideration. And to do that, we need more research and high quality data. Thank you so much for your attention.
Vielen Dank.